Thank you, Mark. Good morning, everyone. I'm delighted to be here and start the meeting off. This is the 27th annual meeting, and I have been honored to participate in many of these meetings, including the first meeting that we had in Houston. But before I go forward and start reviewing the topic that Dr. Hallett asked me to review, I just wanted to pay tribute to Dr. Hallett. He's the current chairman of the Scientific Advisory Board, and he has done a splendid job leading the advisory board in reviewing the various grants and working very closely with Mary Lou and the other leaders of the Blepharospasm Foundation. So, Mark, thank you for all the effort you have put into this very important project. So I don't know if this is going to work. Well, I just wanted to show the picture from the very first meeting we had in Houston in October of '82, and this is, I think everybody recognizes Mary Lou Castro, who is the founder of the Benign Essential Blepharospasm Research Foundation, and she was a remarkable woman. I'm sure you'll be hearing more about her throughout the day and this evening. She had very good taste in men. You can see she always liked the more handsome men. This is Dr. Anderson. This is Dr. Wilkins. This is from our 20th Blepharospasm meeting in Houston to celebrate the 20th anniversary. And this is the faculty from that meeting. You recognize many of the people here. There will be speakers also today. And this is today's faculty that we took a picture we took last night during a lovely dinner hosted by Allergan and by the Blepharospasm Foundation. So again, I'm delighted to be here and start reviewing the topic of Blepharospasm and Hemifacial Spasm. So I'm just going to give some introductory remarks just to highlight some of the clinical features of Blepharospasm and Hemifacial Spasm, and then subsequent speakers will embellish it and enhance the topic and talk about some other issues related to Blepharospasm. David Marsden, who was a very close friend of both Dr. Hallett and me, first pointed out that perhaps the first depiction of Blepharospasm was in a picture by Flemish artist Bruegel in the 16th century, where in this picture there is some suggestion that this person has a Blepharospasm with involuntary closure of the eyes and jaw opening, which is often an accompaniment of Blepharospasm, and he suggested that this condition really should be referred to as a form of dystonia. We'll talk a little bit more about the relationship between Blepharospasm and dystonia later. So that was the first time that anyone has made a link between Blepharospasm and this condition called dystonia. It turns out that actually the first person who described Blepharospasm in a clinical scientific literature was Horacio Wood, who was a doctor in Philadelphia, the first chairman of the first neurology department in North America. And in his 1887 article, he noted that the facial convulsions are in some cases limited to isolated muscles. The Orbicularis Oculi, he called it, we'll refer to that later, is especially prone to suffer, giving rise to the affection known as Blepharospasm. And that is, I think, the first occurrence of the word Blepharospasm in a scientific literature. He said the contraction is tonic, causing a complete closure of the eye and consequent blindness. This is accompanied by innumerable bizarre grimaces due to the efforts of the antagonistic muscles to overcome the force which is closing the lids. So he got a little bit wrong. He thought that these other spasms in the face besides Blepharospasm are due to attempt by the patient to correct the Blepharospasm. We now think that these spasms in the face that involve the face other than the eyelids might be actually part of this condition called dystonia. Now, another term that you sometimes hear is the term Meige syndrome, which is named after a French neurologist who described a group of women in 1910 who had spasms of the face, including the eyelids, but also had the spasms of the mouth, jaw, and tongue. But Henry Meige was obviously not the first one to describe this condition. As I pointed out, Horacio Wood was actually the one who described before. And therefore, we believe that the term cranial cervical dystonia is the term that is most appropriate to describe the combination of blepharospasm and other facial spasms. So I'm just introducing some terms that you will be hearing throughout the day, and I want to define them for you in some detail. So blepharospasm is often wrongly named benign essential blepharospasm. There's really nothing benign about blepharospasm. Those of you who have blepharospasm, I'm sure would be much happier without it. There is nothing essential about blepharospasm. Again, you can certainly live without blepharospasm, so there's nothing essential about it. So I don't particularly really like the term benign essential blepharospasm. I just use the term, blepharospasm. We already talked about Meige syndrome. We don't particularly like eponyms anyway, and Henry Meige was not the first one to describe it, so it's not a good term. Bruegel syndrome, which is the term that David Marsden suggested based on that painting, also I don't think is appropriate because we really don't know the history of that individual. For all we know, this person that I showed you the picture of could have been just yawning and had no problem at all. So we still prefer the term focal dystonia to describe this condition called blepharospasm. Now, what is dystonia? Dystonia is a neurological disorder dominated by involuntary, sustained, or spasmodic, repetitive, and pattern contractions of muscles, frequently causing twisting, squeezing, like blepharospasm, and other abnormal movements or postures. And you'll be hearing more about it, so I'm not going to go into this in any detail. So let me just describe some of the characteristic features of blepharospasm. It consists of intermittent or persistent bilateral, meaning both eyes, but often asymmetrical. It doesn't have to be symmetrical. It may be asymmetrical. Involuntary eyelid closure produced by spasmodic contractions of the Orbicularis Oculi, which is the main muscle of the eyelids that closes the eyes, and also other muscles, particularly eyebrow muscles, such as the procerus and corrugator muscles. And you may wonder, what are all these muscles? So here you see the muscle called Orbicularis Oculi, and here are the muscles procerus and corrugator. So this is just a very rough description of these muscles. Now, Orbicularis Oculi, which is the main muscle that closes the eyes, has three components. The orbital, septal, and pretarsal components are shown here. And this is going to be particularly important when we talk about the use of botulinum toxin in the treatment of blepharospasm, and the speakers who will be talking about it will probably be referring to these three components of the Orbicularis Oculi. So blepharospasm often is not alone. There are other spasms that may occur in the face, jaw, and tongue. We call it cranial cervical dystonia, or larynx. So people may have abnormal voice, so they may talk like this. They have a so-called adductor spasmodic dysphonia, or they may be talking like this in a very breathy voice, which is called abductor spasmodic dysphonia, where the various muscles of the vocal cord either come together, they adduct, or come apart, they abduct. Or they may have spasms of the neck muscles that we refer to as cervical dystonia or torticollis, or they may be part of a generalized dystonia where they have spasms involving not only the face, neck, but also the trunk, arms, and legs. And as part of this generalized dystonia, they may also have blepharospasm. And that's illustrated here so that patients often have blepharospasm. They may have oromandibular dystonia with jaw closure or jaw opening, cervical dystonia with turning of the head or flexion of the neck, or extension of the neck, and the spasmodic dysphonia, this funny voice that I tried to illustrate. These are some of the components of the cranial cervical dystonia. Many patients with these focal dystonias also have tremor, shaking in the hands or other parts of the body that we refer to as essential tremor. And there's some controversy as to what is the relationship between this condition called essential tremor, which is the most common form of tremor, and dystonia. That's a subject for another discussion. So So blepharospasm often starts with sensitivity to light, increased frequency of blinking, and despite the fact that the patients cannot see because of the eye closure, their visual acuity is actually well preserved. But because of the inability to see, they have difficulties reading, watching TV, driving, performing activities of daily living. Many of them also complain of discomfort or pain as part of the blepharospasm. Now, there are a variety of sensory tricks that patients with blepharospasm have learned, and many of you who have blepharospasm, I'm sure, have adopted these tricks in order to control the blepharospasm. We call it sensory tricks or just antagonistique, which is a French term for sensory trick. Dark glasses often help. What are some of the sensory tricks? Pulling on upper eyelid, touching the forehead or eyebrow, pinching the neck, humming, singing, coughing, yawning, and talking. And many of you know that when you talk, your eyes remain open, and it's nice to have a blepharospasm patient for dinner because you can just sit back and let them talk because they keep their eyes open. It is better when concentrating or while looking down, but worse at rest or while looking up. Progression may be rapid. I've seen some patients who develop blepharospasm over a period of several days or weeks, but in most cases it progresses over several months or even years. There are often fluctuations, so many of you who have blepharospasm know that you have good days and bad days. Why you have good days and bad days, we may not be always able to determine that, but stress does sometimes make the blepharospasm worse, and that's one of the reasons why patients with blepharospasm are often misdiagnosed as having psychogenic or some kind of psychiatric disorder.
My eyes, they will not stay open.
Okay.
And they want to squeeze.
I want to show an example of the sensory tricks.
I can't see.
How long have you had symptoms?
This is getting close to 3 years.
Okay. Can you hold them open?
If I sing, maybe. I don't know.
Okay. Do you drive?
Mm-hmm.
So she can keep her eyes open when she
Can
sings.
you go ahead and sing to see what happens?
One day at a time, sweet Jesus, that's all I'm asking from you. Just give me the strength to do every day what I have to do.
So do you sing all the time? You do?
Pretty much.
Does it have to be out loud?
Mm-hmm. Mm-hmm.
Okay. You can't sing just in your mind, right?
I don't think I've ever tried that. It seems like it helps to sing, so I just do it.
Okay.
I mumble, but I hum, I do noises.
So whenever I see her, she keeps humming all the time while I'm talking to her, but that's the only way she can keep her eyes open. Now, there are many reasons why people have trouble keeping their eyes open, and I'm not going to talk about some of the ocular disorders that can cause involuntary eye closure. That's going to be the topic of the next lecture by Dr. Savino. But there are many, many ocular disorders that can cause involuntary eye closure, including dry eyes. Another reason why people cannot open their eyes is because they have weakness of the eyelids. So it's not just an involuntary closure due to contraction of the eyelid muscles, but weakness of the eyelids that prevents them from keeping their eyes open. And there are many reasons why people develop weakness, or they may have excessive tissue in the eyelid, so-called dermatochalasis. And I want to show you a video of a patient who has dermatochalasis because he had chronic blepharospasm, had stretching of the skin and the tendons in the eyelids, and developed this excessive tissue in the eyelid that prevents him from keeping the eyes open. So it should be linked to the video. So this is a college professor who has had a long-standing blepharospasm, developed dermatochalasis. That he's showing this here, and this would not be helped with botulinum toxin because you cannot remove the excessive tissue with botulinum toxin. These patients probably will require surgery. Or he's using these eyelid crutches. And that's one way he can keep his eyes open. So this is just a trick that he has learned, and we're using these eyelid crutches frequently in patients who have either dermatochalasis or ptosis or some other reasons why they cannot keep their eyes open. Another condition that interferes with ability to open the eyes is a condition called apraxia of eyelid opening. And this is an important condition to recognize. And whenever we see patients who are referred to us because they, quote, are unresponsive to botulinum toxin, unquote, we often think about apraxia of eyelid opening. So this is an inability to open the eyes once the eyes close. And there are many reasons for that. Again, I'm not going to go into a long discussion why patients have inability to open the eyes once the eyes close, but it is often seen in a setting of Parkinsonism, either Parkinson's disease or some other condition. So that's one of the things we always think about, although it may be so-called idiopathic, meaning there's no specific cause for it. So let me show you some examples. So I asked the patient to close their eyes and then open their eyes, and she's unable to open their eyes. You could see that there was a delay in her ability to open the eyes. Okay, so this is so-called apraxia of eyelid opening. When we see that, again, we think of Parkinsonism or Parkinson's disease or some other conditions. And then the next patient I'm going to show you has a similar condition due to Parkinson-type condition.
And open it.
Okay, so it's apraxia of eyelid opening. It's a very important condition to diagnose and differentiate it from blepharospasm, which is due to involuntary eyelid closure.
Progressive supranuclear palsy.
So this is a patient with progressive supranuclear palsy, Parkinson-type condition.
Of eyelid opening. The botulinum toxin injection into eyelids and eyebrows markedly improved both conditions.
So she has blepharospasm and apraxia of eyelid opening. So if you ask her to open her eyes, she cannot do it. She has to use her fingers to open her eyes, and even then, she's unable to do that. And this is before we injected her, and I'll show you in a minute how she responded to botulinum toxin injection. So even though apraxia of eyelid opening is a little bit more challenging to treat with botulinum toxin, nevertheless, many patients do improve if the treatment is administered appropriately. So there are many reasons, again, why patients have inability to open their eyes. Reflex blepharospasm is seen in newborn infants. People who have stroke or have other kind of brain conditions have what is called reflex blepharospasm. When you shine light into their eyes, they close their eyes. We already talked about dystonia, and the blepharospasm is one example of dystonia that can cause involuntary eye closure. I'll show you an example of tardive dystonia in a moment. Tardive dystonia is a condition that is due to exposure to drugs that are used to treat psychosis, like thorazine and stelazine, and these drugs that are not frequently used anymore, but even the newer drugs, the newer antipsychotic drugs can cause this condition. And there are drugs like Reglan, which is used for gastrointestinal problems, reflux, that can also cause this condition called tardive dystonia. Chorea, such as Huntington disease, myoclonus can cause involuntary eye closure, and tics in Tourette syndrome. So here's a patient with tardive dystonia. She was exposed to these antipsychotic medications and developed blepharospasm as well as oromandibular lingual dystonia. So the exposure to these drugs certainly can cause blepharospasm. It's one of the first questions we ask when we see patients with blepharospasm, whether they were ever exposed to these drugs, because the treatment is often different. And can be treated with tetrabenazine, such as in this patient. So the drug tetrabenazine, which was recently approved by the FDA for the treatment of chorea associated with Huntington disease, can also improve tardive dystonia. Now here's another example of blinking due to Tourette syndrome. So this young woman has Tourette syndrome with tics that involve the eyelids, involve the blinking type movement that could be misdiagnosed as blepharospasm. Okay, I'm going to shift gears and talk about hemifacial spasm, which is another topic that Dr. Hallett asked me to discuss because it often comes up in the differential diagnosis of blepharospasm. So in contrast to blepharospasm, which as I mentioned before which is a bilateral condition involving both eyes, although it may be involving one eye more than the other, it could be asymmetrical. This condition that I'm going to talk about now, called hemifacial spasm, involves only one side of the face. Okay, and the cause of hemifacial spasm is completely different from the causes that we discussed for blepharospasm. So this is from a review that we published some time ago of 158 patients that came to us with hemifacial spasm. Majority of these patients were women. They started around the age of 48 or so. It was about 11 years before they actually came to us and were diagnosed as having hemifacial spasm. The left side is more frequently affected than the right side. Rarely, very rarely, both sides may be involved, but when both sides are involved, they are involved in an asynchronous way, meaning that one side of the face contracts in a different way, in a different pattern, different frequency than the other side of the face, and I'll show you some examples of that. It usually starts with the lower eyelid twitching, and then it progresses to the upper eyelid and the other side, other parts of the face, and it's the same side of the face is always involved, and it's the part of the face that's innervated by the facial nerve. The facial nerve is one of 12 nerves, cranial nerves, that innervate muscles of the face. In some cases, it is also associated with pain, so-called trigeminal neuralgia. It's very rare, but when it does occur, it has to be treated separately. And occasionally, we see patients with hemifacial spasm following Bell's palsy, which is a condition that usually occurs after some infection of the inner ear, usually like a herpes infection or some other cause that causes facial paralysis, Bell's palsy, and then when they recover from their Bell's palsy, they have hemifacial spasm. It is best treated with botulinum toxin injection, although in the old days, the surgeons would often go in and remove a blood vessel away from the facial nerve in order to relieve hemifacial spasm. These vascular decompression type surgeries are rarely done now because botulinum toxin is usually so effective. So here's an example of a patient with hemifacial spasm. She came all the way from China. And you can see the twitching on the left side of the face.
I have hemifacial spasm.
Okay. How long has this been going on?
About 2 years.
Okay.
And you can see that this is very troublesome, very embarrassing to her. She's a very prominent individual in China and has a lot of public appearances. Now, her husband came with her.
Her husband?
Yeah.
Okay.
And he has the same condition.
You also have the same problem?
I got the same problem like hers.
Okay.
But he was not bothered by that because he had it for a long time and he thought that it was normal. It turns out that this condition, hemifacial spasm, is much more common in Asian population.
And how long have you had
than
this?
in Caucasian population.
It's about 5 years.
Okay. And by touching your face, it makes it better?
Yeah, when I press this point, it will stop.
So he has learned a sensory trick that helps him control the hemifacial spasm.
Try not to touch it now.
Here's an example of somebody who has bilateral hemifacial spasm. It's quite rare. And you can see that she has the twitches in the face that are asynchronous. They are not occurring together, like, for example, in somebody with cranial dystonia.
Ma'am, have you ever had weakness on one side of your face?
So that's bilateral hemifacial spasm. And here you see an X-ray showing the abnormal blood vessel that is compressing the facial nerve. So in some cases, the blood vessel has to be removed or moved away from the facial nerve surgically. But as I said before, that surgery is not performed very frequently. There's another interesting aspect of hemifacial spasm which helps us differentiate it from Blepharospasm, and we call it the other Babinski. Babinski was a very famous Russian neurologist who studied in France, and he described the so-called Babinski sign, which is probably the most well-known sign in neurology. I'm not going to go into this why it's important, but he described this other sign that is now referred to as the other Babinski sign. And what he was referring to was that in patients with hemifacial spasm, like for example this one, there is often an elevation of the eyebrow on the side of the hemifacial spasm. So if this patient had Blepharospasm, you would expect the eyebrow to go down, to be depressed, whereas in a patient with a hemifacial spasm, the eyebrow goes up. and this is called the other Babinski sign, and we described it in a paper a couple of years ago and noted that it has 100% specificity for hemifacial spasm, and it clearly differentiates hemifacial spasm from blepharospasm. So it's a useful sign that we often teach our fellows to help them differentiate hemifacial spasm from blepharospasm. Another condition that can cause facial twitching that is sometimes confused with hemifacial spasm is a condition called myokymia. You can see these undulating contractions of the facial muscles. This is often seen in patients with multiple sclerosis or with brainstem tumors or after some facial paralysis. Again, it's an important condition to recognize because the investigation and the treatment is quite different than in patients with blepharospasm. So there are many other causes of eyelid closure that we don't have time to discuss, but I just put out the slide to illustrate what the neurologist or ophthalmologist has to go through in order to come up with a diagnosis of blepharospasm and exclude other causes for the involuntary eye closure. I'm going to close with this video of a patient who has blepharospasm, orbimandibular dystonia. I saw her almost 20 years ago, and I treated with botulinum toxin, and you can see how much she improved.
Completely. I have no trouble whatsoever with my eyes right now, and that will last approximately 4 to 5 months.
And then 15 years later, she continues to benefit from botulinum toxin, and her eyes remain open, and she's obviously...
Ma'am, it has been at least 15 years since we first injected you with botulinum toxin.
Right.
How would you compare yourself now to the way you were before the very first injection?
Well, now I have no symptoms of the disease at all that I have to contend with. Before I saw you, I was almost incapacitated completely. I couldn't open my eyes. I was having trouble eating because my muscles in my face wouldn't cooperate, and I had just about decided that I was going to be an in-house patient.
Okay, so I'm not going to go through the whole video, but there's clearly hope for patients with blepharospasm. Botulinum toxin is the treatment of choice, but some other treatments that we'll be talking throughout. When I was in South Korea, in the Jeju Island, I found out that there's another treatment, and I have not applied that treatment yet, but Dr. Hallett, I think, is going to talk about a double-blind controlled study sponsored by NIH. Maybe we're looking into this. And I'm going to leave you with this thought by Benjamin Franklin. He said, keep your eyes wide open before marriage, but half shut afterwards. That's just something to think about. And then finally, I just want to pay tribute again to our founder, Marilu Castro. One of the greatest honors I ever had was to have Marilu call me her second son. So I've been very close to her, and obviously miss her very much. One other honor I had was I was asked to speak at her memorial, and this is what I said: I will always hold on to the memory of this most remarkable woman and be eternally grateful to her for the legacy she left behind, especially her daughter, Mary Lou, and the army of loyal followers. And many of you are obviously her loyal followers, and this is Mary Lou, who is obviously stepping into the shoes of her mother in a very magnificent way, and finally achieved the ultimate award, the Life Achievement Award, which was given to her yesterday. And I want to take this time to congratulate Mary Lou on this very